So, hello everyone. We'll start with a lecture of hypothyroidism. We are dealing with a Harrison-based, which is a 21st edition Harrison-based topic. And here in this, we will cover the introduction, the causes of hypothyroidism, then congenital hypothyroidism, autoimmune hypothyroidism, any other causes and treatment. First, we'll start with the introduction. Okay, hypothyroidism is the hypothyroidism is the second most endocrine disorder after diabetes mellitus. We know that the India is the diabetic capital. So after diabetes mellitus, the second most common endocrine disorder after diabetes mellitus is the hypothyroidism. The most common cause of hypothyroidism worldwide is iron deficiency. This is very common. So the most common cause in iodine sufficient area is Hashimoto's thyroiditis. We should understand that Hashimoto's thyroiditis is uh, it's an autoimmune case. So the most common cause in iodine sufficient area is Hashimoto's thyroiditis. Also, also iatrogenic causes. Okay. So next come the most 99% of cases. This hypothyroidism is always primary. The gland itself is affected, and only 1% of cases the secondary hypothyroidism occurs. Okay. So we have completed the first topic, that is the introduction regarding the hypothyroidism. I have briefed it from the Harrison's textbook. So secondly, the causes of hypothyroidism, which is given in the 2933 page number. So let us see the causes of hypothyroidism. The table is given in the Harrison's textbook. We can divide it into mostly primary causes, secondary causes, which are very much less than 1%. Then you have transient causes. Okay, so first we discuss the primary causes. Autoimmune hypothyroidism, we already told, that is the Hashimoto's thyroiditis, antibodies against the thyroid gland. Then atrophic thyroiditis. Iatrogenic causes means the iodine 131 treatment. We know in case of diagnostic treatment modalities, investigations, we use iodine 131 also for the treatment in subtotal total thyroidectomy. And drugs like excess iodine and sunitinib, it's a inhibitor, kinase inhibitor. Then immune checkpoint inhibitors like ipilimumab, nivolumab, pembrolizumab. Okay. Then congenital hypothyroidism, we know that absent or ectopic thyroid gland dysharmoniogenesis, or TRS, which are mutation, iodine deficiency, infiltrated disorders like amyloidosis, sarcoidosis, hemochromatosis, cystinosis, reverse thyroiditis, overexpression of type 3 deiodinase in infantile hemangioma and other tumors. It's the secondary hypothyroidism, where the thyroid gland itself is normal, but secondary to some other problem in somewhere else, maybe glands or somewhere, there is a hypothyroidism. First one is hypopituitarism. The pituitary tumors, pituitary surgery, radiations, Sheehan syndrome, that is deficiency or inactivity. Then hypothalamic disease like trauma, tumor infiltrate disorder, and Bexarotene treatment. It's a treatment. It's a drug which is given in case of cutaneous T-cell lymphoma. We give in cutaneous T-cell lymphoma. We give it in case of a cutaneous T-cell lymphoma. Okay. So that is a secondary cause, and next comes the transient cause, the silent thyroiditis, including postpartum thyroiditis, subacute thyroiditis, withdrawal of supraphysiological thyroid treatment in individuals with an intact thyroid after 131 treatment. So these are the causes of congenital hypothyroidism. The prevalence is very less. That is just in 4,000 newborns, only one will be affected. Okay, it's less, and can be transient if the mother has TSH receptor blocking antibody, or in patients with patients, or in mothers who are receiving, in mothers who are receiving anti-thyroid drugs. Thyroid drugs. So next, the causes of congenital hypothyroidism. The majority of cases, that is 80 to 85% of cases, the problem lies that the thyroid gland itself is not formed. It's dysgenesis of thyroid gland. Okay, and only in 10 to 15% there is inborn error of thyroid hormone synthesis. In 5% cases, that is a TSH receptor antibody mediated. So the most common is dysgenesis. Okay. Also, there are certain gene mutations which are also been identified, like PROP1, PROP1, PIT1, TSHR, TSH beta, thyroid peroxidase, thyroglobulin, pendrin, like that. The clinical manifestations of hypothyroidism, the congenital hypothyroidism. Majority of cases, the patient will be, the child will be normal at birth, and in few cases are diagnosed on basis of clinical features and biochemical screening. Usually we do test on the sixth day, okay, sixth day after birth. Clinical features include prolonged jaundice, the feeding problem, hypotonia, enlarged tongue, umbilical hernia, delayed bone maturation. Everything is the clinical maturation. The complications include congenital malformations, which is 4 times more occurring. Then permanent neurological damages. Diagnosis and treatment is neonatal screening. The measurement of TSH or T4. It is a heel prick blood sample. The treatment dose is we give T4, that is a 10 to 15 microgram per day. Here we should understand one thing, that is the T4, that is a levothyroxine we are giving. That is, we told it is 10 to 15 microgram per day. But in case of adult, we know that in adult we give around 1.6 microgram uh, per kg per day. Why? It's because uh, the T4 requirement for a newborn is more than adult. Okay, since it is very much lower compared to this 10 to 15 microgram. It's per kg per day. Okay, so here we will discuss about the classification of autoimmune thyroiditis. We have discussed congenital hypothyroidism is over. Next one is autoimmune thyroiditis, hypothyroidism. So here we should understand that it's classified into two. That is Hashimoto's, or it is also called the goiterus. It's goiterus thyroiditis. Thyroiditis. Next is atrophic thyroiditis. It's a late stage where only very small tissues are present. So for easier understanding, I have drawn a table which is starting of this disease, autoimmune destruction, progression of autoimmune destruction, completion of autoimmune destruction. During the starting stage, there will be normal TSH, normal T4, so that is normal gland. When it progresses to the second stage, the TSH will be, that is Hashimoto's thyroiditis. It is the TSH will be high. That high TSH will be able to maintain the normal thyroid hormone, so the T4 will be normal. It is also called subclinical because no much clinical presentation of symptoms. When it completes, that everything, the thyroid hormone production is very less, so negative feedback TSH will be high, that is atrophic. So we should understand this important table. Next, the prevalence of this disease, that is Hashimoto's, is mostly seen in women. 1,000 women, 4 per. In men, only 1. Okay. Mean age is 60 years, we will see. Subclinical hypothyroidism prevalence is 6 to 8% in women and 3% in men. Okay. Pathogenesis. So now we will discuss what is the pathogenesis of this Hashimoto. There are two types, genetic and environmental causes. So first one we will discuss, that is what is genetic. That is associated HLA-DR3, D4, D5, CTLA4, which is a T cell regulatory gene. Okay. Then it's associated with Down syndrome, Turner syndrome, other autoimmune diseases like type 1 diabetes, Addison's disease, pernicious anemia, vitiligo. Environmental factors simply means a high sodium intake, low selenium intake, decreased exposure to microbes in childhood, smoking cessation, alcohol. This is a protective mechanism. Then we have to see that what is Hashimoto's thyroiditis and atrophic thyroiditis. In Hashimoto's thyroiditis, we must understand that there is a marked lymphocytic infiltration. The lymphocyte will be infiltrated there. The germinal center formation, atrophy of thyroid follicle, oxyphil metaplasia, oxyphil cells will come. Then absence of colloid, because it's a autoimmune destruction will be there. Mild to moderate fibrosis, that is a late stage. In atrophic stage, extensive fibrosis, very late stage. Lymphocytes will be infiltrating. that will be less. Why? Because lymphocyte infiltration is mostly seen in the early stage, that is Hashimoto's thyroiditis. Later, the immune system won't get stimulated that much faster. The thyroid follicle will be completely absent. Usually, the end stage of the Hashimoto's is atrophic thyroiditis. Okay. Then we have so the antibodies are related to the Hashimoto's thyroiditis. First, we should understand that in antibodies, there are 20% of patients there will be TSH antibody blocking type of TSH antibody. That is, when TSH coming from the pituitary gland, it is blocked by these antibodies, which is produced by the body. Similar to the uh, thyroid stimulating immunoglobulin of Graves disease. Okay, in Graves disease we have seen such things. So similarly, it is a TSH antibody blocking type. It's responsible for transient neonatal hypoglycemia. It is responsible for transient neonatal hypothyroidism if a transplacental movement of this antibody occurs. Okay, TBI is also actually that is thyrotropin binding inhibitory immunoglobulin. The TBI assay can detect the antibodies, just measure the amount of antibodies binding to the TSH receptor. So therefore, these will do not differentiate between the blocking as well as stimulating antibody. We have to correlate clinically along with the TBI assay result. If TBI is positive, and along with that there is a hyperthyroidism, that is a hyperthyroidism, then we could say that it is a thyroid stimulating immunoglobulin. If it is a hypothyroidism, then it is TSH receptor blocking antibody. This is stimulating. Okay, this is the here. Then we have anti-TPO, anti-T thyroglobulin immunoglobulins. The cytokines which include the lymphocytic infiltration T and B cells, the CD8 plus cytotoxic T cells, and the cytokines like TNF interleukin 1, immunoglobulin gamma, like that. And it is associated with the increased thyroid gland apoptosis. So here the clinical manifestations of Hashimoto, which is insidious onset. Okay, the Hashimoto goiter rather than other features, it will occur as a goiter, which is irregular and firm in consistency. Next, atrophic thyroiditis or late stage of Hashimoto present symptoms and signs of hypothyroidism. Okay, hypothyroidism symptoms, because if the gland is atrophic, so that the signs and symptoms of hypothyroidism, there is a descending order of this frequency, we can see the signs and symptoms. The symptoms include like tiredness, weakness, dry skin, feeling cold, high nail loss, then difficulty concentration and poor memory, very important. Then constipation, weight gain in spite of poor appetite, very important. Next, dyspnea, hoarseness of voice due to vocal edema. Okay, edema of the vocal cord, vocal edema. Then menorrhagia. Later there will be oligomenorrhea, menorrhagia, excessive bleeding, then infrequent bleeding, then amenorrhea. And paresthesia and impaired hearing. The signs that we can observe is that dry, coarse skin, the cold peripheral extremities, very important. Then we have a puffy face, hands and feet. There is mixed edema, then diffuse alopecia, and bradycardia, because the thyroid hormone is a tachycardic hormone. Okay, peripheral edema, delayed tendon reflex. There is a brisk tendon reflex can be observed. And carpal tunnel syndrome in the hands, carpal tunnel syndrome, serous cavity effusion. The Hashimoto encephalopathy is a rare feature. The signs of and symptoms of other autoimmune diseases, then the thyroid-associated ophthalmopathy in case of 5% of patients. Okay. When we're dealing with the Hashimoto's encephalopathy, it is a steroid responsive syndrome. Then it is a TPO antibody will be positive. Then there will be myoclonus, and we can rarely see some slow waves in EEG. Okay, these are the features of a Hashimoto encephalopathy. Here we can also see the signs and symptoms of other autoimmune disease like vitiligo, alopecia areata, like that. Okay, so in children the autoimmune hypothyroidism occurs, so it's very uncommon. Okay, and if it is present, it will be slow growth, delayed facial and dental development, maturation, myopathy, muscle swelling, delayed puberty, intellectual disability. occurs when this hypothyroidism occurs if in less than 3 years of age of a child, and if it is severe, this intellectual disability will occur. Okay. For the laboratory evaluation of hypothyroidism, we should keep in mind that in 95 percentage of cases, there will be positive anti TPO antibody as well as positive anti thyroglobulin antibody, and also in 10 to 20 percentage of cases, the thyrotropin binding immunoglobulin, that is a TBII, will be positive. Okay. Then the laboratory evaluation of hypothyroidism. First, if the TSH is elevated, we see a high amount of TSH. Measure the unbound T4 level. Okay, measure the unbound T4 level. If the T4 level is low, okay, we can say that it is a primary hypothyroidism. Okay, primary hypothyroidism. In primary hypothyroidism, there are two cases. The thyroid peroxidase antibody is positive and thyroid peroxidase antibody is negative. If the thyroid peroxidase antibody is positive, means the autoimmune attack on thyroid gland, that is autoimmune hypothyroidism. Okay, so we should give treatment for T4 treatment, that is levothyroxine. Okay, next, if the TPO antibody is negative, we should look for the other causes of hypothyroidism. It can be iatrogenic, or it can be iodine deficiency, like that. It can vary. That is the case of a high TSH and low T4. Next is this one. We are telling that if you're seeing that the normal T4 level, we should say that it's a mild hypothyroidism. Okay, or we can just say it's as a subclinical form. Okay, then we should also check here similarly the TPO antibody positive or symptomatic. We just start with the T4 therapy. Even though the liver is a low T4, sometimes there may be slight decrease in T4 in future. That is why we are starting with levothyroxine. If a TPO antibody is negative, we just require an annual follow-up, because even though TSH is elevated, the production of the antibody, the production of the hormone from the glands is normal. Okay. So next is this measuring TSH. We found that the TSH is normal. Okay, the TSH is found to be normal. If we suspect a pituitary disease, are you suspecting a pituitary disease, just measure the unbound T4 level in your blood. Okay, and if you see that the unbound T4 level in your blood is normal, there is no need of any further test. And if you found that unbound T4 level in your blood is low and the TSS is low, is normal, which means that something is happening to the gland. The autoimmunity is also cannot be ruled out, but here the rule out the drug effect or sick thyroid syndrome, then evaluate anterior pituitary function. Okay, anterior pituitary function should be evaluated, because sometimes the TSH may be normal in anterior pituitary problem also. So if there is no pituitary suspicion, no further test is required. It's just okay. We are going to discuss the other causes. Here we have some major other causes like iatrogenic cause, radioiodine therapy treatment. In certain diseases, we use radium iodine therapy, iodine 131, 123, like that. In such cases, the gland will be affected and the production of the hormone will be reduced. Next is the subtotal thyroidectomy. An iron deficiency like endemic goiter cretinism, which is uncommon in adult, public health measures about this condition. It's a very rare condition nowadays. Iron excess. Chronic excess can induce goiter and hypothyroidism. In certain drugs like amiodarone is very important. Lithium is also very important. It can cause hypothyroidism. Secondary hypothyroidism, we should see that the TSH level can be either normal, low, or it can be, as we told, it can be even slightly increased. So here will be having an important question. If in secondary hypothyroidism, if the TSH level is high, because it can be normal, low, or high in pituitary problems, then why it can stimulate the TSH receptor and maintain a euthyroid state by producing the UNF hormone? Why? Because this TSH hormone produced is immunoactive, which can easily be detected in assay, but it is bio inactive, which cannot act on TSH. No action on TSH. Okay, that is why very important point. Okay, this is a normal doubt that we encounter while doing this. So now we'll discuss about the treatment of hypothyroidism, clinical hypothyroidism. So you should understand that the dose of levothyroxine to be given is about 1.6 microgram per kg per day. That comes around 100 to 150 microgram per day. Okay, 100 to 150 microgram per day to be taken. So how much ideal time is before, that is 30 minutes before breakfast, because the breakfast uh, will act or the affect the absorption of this uh, levothyroxine. The goal of treatment to maintain normal TSH level. That is, the range should be uh, more towards the lower limit. Okay, and TSH monitoring can be done over just 2 months. Okay, symptomatic relief when the normal, if a normal TSH is happened after the treatment, after normal TSH, normalizing the TSH, it takes 3 to 6 months for the symptoms to get relief. Okay, over treatment, if the risk of over treatment, it can cause suppression of TSH, and also it will cause atrial fibrillation, and it will decrease the bone marrow density. Adherence, do not feel any difference. The problem is that if a patient misses a single dose, she or she does not feel any difference. She said that even though I missed today's dose, I don't have any problem. No, there is a problem. If you miss a single dose, then next day you take the 2 doses. Okay, 2 doses. That is, if you miss 100 today, take 200 tomorrow. Increased requirement in case of malabsorption. Okay, malabsorption in case of estrogen therapy, also in case of bile acid sequestrant, in case of ferrous sulfate or calcium treatment. In such cases, we need increase dose requirement. That is main points regarding this. So we are encountering some cases like subclinical hypothyroidism. Okay, subclinical hypothyroidism, where there will be normal T3, T4 level, and there will be increased TSH level. TSH level will be increased, and T4 and T3 level will be normal. That is why we are always asking the patient to check the TSH, because mostly we are seeing many subclinical cases. So if the TSH is more than 10, and if TSH is less than 10, in both cases the treatment is required. That is symptomatic goiter, family history of autoimmune thyroid disease, planning pregnancy, TPO antibody positive, evidence of heart disease and dyslipidemia, infertility, psychiatric disorder. In such, less than 10 with these criteria. Okay, the dose should be around 25 to 50 microgram. It could be it can be elevated, can be adjusted 12.5 accordingly. We can adjust the dose. Here we have to discuss some special consideration in pregnancy. We should say in pregnancy that the thyroid function should be monitored. Why? Because it is a difficult condition, because it can cause fetal development. It can cause miscarriage. So it's very important to check the TSH level before conception. Therapy to target TSH in normal range. Okay, every 4 weeks we should check the TSH in first half of pregnancy. Okay, then levothyroxine dose is increased by 45%. Okay, after delivery we should to the pre-pregnancy level. In elderly patient, especially in cardiac patient, the dose should be less, because increased dose can cause AF, atrial fibrillation, or some other cardiac problem. So the slow dosing started like 12.5 to 25 microgram. Gradual increment in 2 to 3 months. In surgery cases, if you do surgery, you should maintain a euthyroid state. That is better in case of surgery. In mixed edema coma, there is a 20 to 40% mortality. Okay. It mostly occurs in elderly patient. The precipitating condition that impair respiration, like drugs, pneumonia, congenital heart failure, MI, CVA, GI bleeds, etc. So we should understand here that both the levothyroxine, that is and T4 and T3 levothyroxines are used. We told that levothyroxine we should start with 200 to 400 microgram IV bolus, followed by a daily dose of 1.6 microgram per kg. Then T3 is we use 5 to 20 microgram, followed by 2.5 to 10 microgram TDS. Why use levothyroxine, that is T3? Because in mixed edema coma, the conversion of T4 to T3, the T3 formation is less. That's why you're using levothyroxine. Along with that, some supportive therapies like external warming, parenteral hydrocortisone, that is 50 milligram every QID. Then treat the precipitating factor, ventilatory support, and hypertonic in case of hypoglycemia and hyponatremia. Okay, thank you so much.